ready to, would you like me to start, Tambo, or do you have to do something to start up?
I just want to introduce you. So I'll
Sure.
start now. 2 seconds. Okay.
Yeah, no worry.
Okay. Good morning, friends. Welcome to the Department of Medicine, CMC Vellore, our academic breakfast, as we call it. Today, I'm very honored to introduce Dr. Vijay Jayachandran, John Vijay Jayachandran, was known as Vijay to all of us. He did his MBBS in CMC Vellore in 1984 and subsequently internal medicine in Indiana University, cardiac and cardiac electrophysiology again in Indiana University. He was for a while a faculty of Indiana University, an assistant professor of clinical medicine, basic and clinical research in medicine and cardiac arrhythmias. He taught cardiac trainees and was the associate editor of the Journal of Cardiovascular Electrophysiology. From 2003 onwards, he's been a practicing clinical cardiac electrophysiologist. He does ablations of complex arrhythmias. He works in Fort Hart Hospital. He's editor is in the editorial review boards of the Journal of Cardiovascular Electrophysiology and the Heart Rhythm Journal. Currently, he is the president of the Texas Heart Health and Vascular Hospital, Arlington, Texas. Vijay has come often, as we were chatting just before this. He has come and helped CMC, has taught a bit in our cardiac EP department and our cardiac PGs. Today, we are really honored that he will take classes for a series of classes for our MD Medicine PGs. And this is aimed at teaching them from the basics of ECG in a practical way, targeted at an MD level, and from then some common arrhythmias and their management in the subsequent classes. Vijay, thank you very much for accepting our invitation. We are really honored and very pleased. So with that brief introduction, it's over to you, Vijay. You can share your screen.
Thank you, Tambu. I just wanted to see, say hello and see if I could see the students. I'll tell you, there's two types of invitations you get, and one in which you kind of think it over a little bit before accepting and so on. I did not take like 2 seconds to say yes to Tambu's invite for this. And I told Asha, my wife, who's also my classmate from Vellore, that I was kind of excited to be doing it. I get lots of, kinds of teaching invitation, but this is a nice one. I also have to set some ground rules. It's going to be interactive, these sessions, except for the first part. I think this one, what we're starting out with today, might just be a little bit of basics and review and not that interactive, but I'll try to put up a few tracings at the end. And here, one thing important for you guys to know, for you students, for the MD students to know, is that you have a great advantage here. I am not going to be your examiner. I am not going to be writing you any letters of recommendation or anything like that. So you can just say whatever you feel like. And when you answer, just feel relaxed and feel like we're just talking through some tracings. So I don't want you to have the stress of kind of a tough EKG session that you would have with one of your professors of cardiology in Vellore, or someone who's going to be your examiner in 6 months. So this is going to be real easy for you guys. So Tambu, I'm going to go ahead and share my screen. Let me see. Then I'll go ahead and enter into full screen view. There it is. Okay. Okay. And so we'll start out just with the basics. When we think about the surface EKG, you have to think about where this starts, where the story starts. And the story starts with the cardiac action potential. And here we just kind of summarize the events of the action potential. You have phase 4, which is the resting period of the cardiac cell, and you have a quick depolarization of phase 0 with sodium and calcium influx, and then further influx of positive ions. And then as these positive ions get pushed out, then the cell repolarizes. And all of this, even though we've just said it in just a few words, is really pretty amazing. In fact, kind of absolute proof of intelligent design. The cardiac membrane is held at this constant, ventricular muscle is held constantly at this negative 80 to 90 millivolts and doesn't vary from there. And as soon as it starts varying from there, as soon as it starts getting even a little more positive, it sets off an action potential. So each cell fires. And the summation of all of that is the surface EKG that we record. So let's talk just through a few basics. If we have, I'm sorry, I just have to move pieces of viewing off my screen so I can see my screen. Simplified cartoon, you have a resting muscle cell, you have negative charge on the inside, positive on the outside, and this is a cell that's not yet fired, so to speak. And as the cell depolarizes, what happens is the positive ions come in, the cell depolarizes. However, adjacent cells are still in the inactivated state, positive outside, negative inside. And you can think of this little interface here as being very small, maybe just think of it as just a millimeter. And sites here that have yet to be activated or in the inactive state are current sources. So these are sources. And these areas here that have just been activated are current sinks. And current actually flows from the positive to the negative. And this little unit, if you could think of, would be considered what we call the cardiac dipole, D-I-P-O-L-E. And as the cardiac dipole moves, you have a wave front of activation. So this cartoon just shows us what electrodes think about wave fronts as they move towards them or away from them. So if you had an electrode on one end of a muscle strip, what you're going to see as the wave front comes towards that electrode is a positive deflection. And if the electrode was recording an area of muscle where it was seeing a wave front going away from it, it's going to see a negative or a downward deflection. If an electrode was positioned somewhere over the middle of a fiber where you had a wave front passing right under it, you would first record a positive as it came towards it, and then a negative going away from it. Now, I want you to just think about this for just a moment and think about a site of stimulation between a couple of muscle strips. And I've picked, I think I took a book published somewhere in the mid 1980s, which is one of my favorite to pull some of these cartoons out of, which is just really keeping it simple. If you think about a point of stimulation between two muscle strips, and if these are of equal size, an electrode at either end would just record positive as the wavefront went towards the electrode. Similarly, you could see here, this electrode records positive as it comes towards it. Now, think about a different situation where you have one piece of muscle that's smaller and one that's larger. If you have stimulation that starts from between these two strips of muscle, you're going to record something a little bit different on either end of these or on the opposing sides of these strips of muscle. On this end, across from the smaller strip of muscle, you might just record the initial positive of the wavefront coming towards it, or you might just record a negative because that is the net of a small amount of propagation through a small strip of muscle in this direction versus a large, think about it as volume, it's actually vector strength going in the other direction. So this electrode might record a small positive followed by a negative or largely negative deflection because the bulk of the muscle is depolarizing away from this electrode viewing from this position. And this electrode that is recording from across or adjacent to the larger strip is going to record a dominant positive potential. Now, just let's linger here for a moment and think about another situation. Here, I've talked about two different sizes, so a small strip and a large strip of muscle. You could also think of this as a piece of muscle that conducts rapidly and one that conducts slow. And what would happen in that case? In that case, this electrode looking at this little strip that is conducting rapidly would see the quick positive coming towards it. And then the rest of the time, while activation wavefront is moving away through this larger strip, I've shown this as larger, but let's think of it as the slower strip. This period of activation would be largely unopposed. I hope that's clear. If this is slow activation, this activation is already complete. And here you have activation that's progressing just slowly across another strip of muscle here. So all of the activation on this side is going to be unopposed. And so you'll just get a negative if you're looking from the other direction, or if you're looking from close to the strip, you're going to get a positive deflection. And Thambu, I'm not sure if the PGs are able to interrupt, but I'm happy for them to pose questions through, or we can wait till the end. I'm certainly going to take questions at the end, but I'm just going to keep moving for now. But if you need to say something, anyone has a burning question, please do speak up.
No, Vijay, what we usually do is they put questions in the chat box and then we can answer them at the end of the session so that it doesn't disrupt the flow of the lecture initially.
Okay, that's fine. That's fine. Okay. Now, you have recording mechanisms that are now much more sophisticated, but this is the basic understanding of how we record all of these activities as recorded on the surface EKG. You record the limb leads, and just a simplified cartoon to show you that you have lead 1 between the left arm and the right arm, lead 3 between the left arm and the left leg, and lead 2 between the right arm and the left leg. And of course, the precordial leads with the first V1 being placed in the fourth intercostal space, just to the right of the sternum, and the V4 being put down right at the fifth intercostal space at the mid-clavicular line, and V6 at the mid-axillary line, and with V3 and V5 just positioned between these. So fourth space and fifth space with the electrodes just spread out. So this is our basic ECG surface lead electrode positions, which you're all, well aware of. Well, let's think about what all this then means in terms of axis and vectors and propagation of muscle, of electrical wavefronts through cardiac muscle over the next few slides. And we're going to come back to this schematic several times through the session. And I'm going to just go over it briefly here. And just a couple of points to remember. 360 degrees, starting from 0 and going in this direction is what we're thinking of. And you essentially go 0 to 180 here and 0 to negative 180 in the other direction. So you have negative 30 at AVL. Think of this as this is where your left arm would be sticking out. Easy to remember, right arm sticking up here in the right upper quadrant, and AVF, the foot electrode, think of F for foot, pointing straight down. And lead 1 towards the left arm, lead 2 and 3 down towards the feet. The only kind of a variation to remember when you're thinking about what to call positive and negative is that AVR would be positive in this direction and negative in this direction. And every division here is 30 degrees. Now, let's think about activation of the heart. And I know you're familiar with the basics of it, but just think about it along with thinking of EKGs. We start out with activation at the sinus node, which is at the upper end of the crista terminalis, which is this thick bundle of muscle along the lateral right atrial wall. And the crista, as it winds up just in front of the superior vena cava here, is where the sinus node is situated. It's kind of draped along the crista from high to low along in this direction. So this sinus node can be a long structure here. As the sinus node fires, you have electrical wavefronts that then activate the atrium, proceeding from high to low. And remember always that I know this might sound a little bit obvious, but always need to keep this in mind, that the right atrium is an anterior structure and the left atrium is posterior. So they should have been called the anterior and posterior atrium. And the ventricle similarly will be anterior and posterior structures as well. And that's really important to remember when you're reading EKGs. It's not so much left and right, it's anterior and posterior structures, even though we call them left and right. As activation progresses down through atrial tissue, you have kind of some preferential areas of conduction. One of them is, hope my mouse pointer is working, but one of them is right in this area here, Bachman's bundle, which is, if you were to picture the heart dissected out from the front, if you were to pull the two appendages apart, you would see fibers of Bachman's bundle connecting the two bases of the two appendages. And so that's a preferential area for conduction across from the right to the left atrium. You also have the superior pulmonary bundle here going towards the right upper pulmonary vein. There's some quick conduction across near the coronary sinus, the opening of the great cardiac vein. These are all preferential sites of conduction quickly over into the left atrium. And then after that, we're going to work our way down to what happens beyond the atrium. But let's think about what kind of wavefront and what does this mean for the axis of the P wave. The P wave vector, as we just talked about, actually proceeds from high to low, and that's classic sinus node firing. The sinus node is situated at a high position, the AV node is lower, you have a high to low activation of the atrium, and in general, from right to left, and from anterior to posterior. And where can we best see these? Where can we best differentiate this? And I think V1 is the best spot to look at this. When you look at V1, the P wave is typically biphasic. I've kind of split and shown you two different examples here. I'm going to show you a little bit more of this. But the initial portion is positive as the right atrium is depolarized, coming right towards V1. And then as the left atrium is activated and proceeds posteriorly, you get the negative deflection in V1. And in lead 2 and 3 that are looking from the feet, you're going to have this positive deflection since the vector of the P wave is inferiorly directed here. You can see this in the frontal plane axis with our divisions here, that the general axis or the general vector of the P wave is high to low and right to left, and the net vector is going to be from anterior to posterior. Now, what about a couple of specific situations where you might see kind of a weird looking P wave and think about, is this ectopic? Is it abnormal? And I'm just going to kind of dwell on this figure here for just a few minutes because it'll help us think about the axis and vectors and their direction, both for the ventricle as well. And why is this all important? It's not just relevant for thinking about, someone hands you an EKG and says, what's the axis? This stuff is actually practical and will help when you start thinking about where a PVC is coming from, what kind of VT you're dealing with is it really supraventricular or a ventricular mechanism? All of these kind of things that will come up as you read tracings. Let's look at a couple of examples here and take on what frontal plane axis would mean when thinking about a P wave. Now let's look at an example of lead 3 here. Now, can you have a negative in lead 3 and this still be a normal P wave? Let's think about that. What situation would cause a negative in lead 3 and still be normal? For that, I think you best come over and look at lead 3 in this little figure here, this little cartoon. What this shows us is that if there is activity proceeding towards lead 3 and the net P wave vector or axis is anywhere in this hemisphere, in this shaded area, you're going to get a positive in lead 3. And if you had a normal P wave vector, let's say somewhere over here, which is positive 15 degrees. Remember, this is positive 30, so this is going to be positive 15. And a normal P wave axis is anywhere between 0 and 90. So anywhere down here in this quadrant is the typical P wave axis. So this can be perfectly normal. But think about this for a second. If the P wave axis falls over here to the left of this line, that's between 0 and 30, let's say at 15 degrees, that's going to be seen as a negative when you're looking at it from lead 3. So these rules are very absolute and they're fascinating. They're very helpful for us to try to decide where a beat is firing from in the heart. And that's really the use of looking at axis, not so much, as I said, just to say what the axis is. Ultimately, it's got to help you do something. And when you look at lead 3 here, you see a negative P wave. It is not an ectopic P wave. This could just mean that the axis of the P wave is falling in this zone here, making it negative in lead 3. Similarly, I took another simple example, which would be, what about if you had, if you had a negative in lead AVL? How could you get that? Let's come over and look at lead AVL. This is going to be AVL shaded here, and this half circle shaded in. If the P wave axis falls anywhere in this half circle, it's going to be positive in lead AVL. And you could well imagine then if a P wave vector fell somewhere between 60 and 90, kind of a vertical P wave firing straight down from top to bottom, you can get this very normal with especially with the vertical heart position that you have in kind of skinny people. And you might have, or P pulmonale, or a kind of a hypertrophied ventricle, you might have a strongly dominant downward positive P wave. You could well get a negative in AVL. If the P wave axis is pointing in this direction, vertical, then AVL, which is looking from this left upper arm direction, remember, this entire half circle is going to be positive. As soon as the vector of the P wave moves beyond that half circle mark and falls here, it's going to be recorded as a negative and still be normal. So that would not be an ectopic P wave. And the only reason I brought these up, not because they're just the most important things to know about P waves, they aren't, but still well worth knowing. And I really think it's more important to use that to think about how axis falls relative to these leads, to these frontal plane leads, and how to think about them as they're let's say, in that half circle related to that particular lead, and to decide which direction your wavefront is moving within the heart. Now, here's another schematic, and I think this is from one of our just our common textbooks. I'm kind of, I think, partial to Braunwald on, since it was written by Zipes, and I pulled certainly some of my illustrations from there. If you were to look at the leads from below, if you're looking at from the feet and you're looking at the right atrium and the left atrium, the right atrium fires first, the left atrium second. If you were to have a hypertrophied right atrium, that's going to be prominent, with the left atrium not prominent. And if the left atrium was prominent and activated late, you're going to have this dominant positive second hump of left atrial activation. Why does this happen? It's that example we talked about two different muscle strips, one being small and one being large. You can imagine if the left atrium is large and being activated gradually, all of these forces are unopposed. And so anything looking at the left atrium is going to record a dominant potential towards it. So if you were to look at lead V1, let's say, which is looking from this direction, what's closest to V1? It's going to be the right atrium. The left atrium, remember, is a posterior structure. If you looked at V1, the right atrium depolarizes towards, or propagates, wavefront propagates towards V1, so you get a positive in V1. And then as conduction then proceeds across the septum and across some of those specialized conduction areas that we talked about to the left atrium and posteriorly, then you get a negative deflection in V1 as conduction is going away from it. And I also mentioned to you, it's going to go largely from right to left. If you were to have significant left atrial enlargement, then you'd have this dominant negative deflection here on lead V1. What happens beyond that? Excuse me. Next would be what happens once conduction clears the atrium. What happens beyond it is we're now down to the level of the AV node. You enter these just amazing structures, the compact AV node, the penetrating bundle of His through the membranous septum, which then splits up into the right bundle and the left bundle, which further divides. And that divides almost promptly into an anterior fascicle and a posterior fascicle. Now, it's not just discrete like this. If we were to show an anatomic figure, let's say even from the most original Tawara diagrams, you'll see just a bunch of fibers going anteriorly, and sometimes even 3 divisions, not just 2 discrete divisions like this, with large bands going posteriorly, which will be the left posterior fascicle. So conduction just proceeds first through the node, rapidly through the AV node, through the penetrating bundle of His, and then into the bundle branches. And this entire little zip of conduction here is not recorded on surface. These structures are too small for it to cause a deflection on the surface. I could show it to you with the intracardiac tracings with electrodes that we place right next to the His bundle, where we can pick up that recording, but not on the surface. And I'm sure we'll look at some of those tracings as well later. As soon as the common bundle of His is activated, the septum is activated from left to right. So the left side of the septum is the initial part of the septum to be activated, and activation proceeds from left to right. And what does that then do for our surface tracing? It's a really important, sounds so trivial, but is an important piece of activation that you always have to keep in mind to decide if an EKG is normal or abnormal. Is there a septal infarct or no septal infarct? What's going on with the Q wave in the right precordial leads? When you are to look at the right precordial leads, which would be V1 and V2, what would you see? You're looking from this direction. You're going to see activation proceed from left to right. So it's coming right at V1 and V2. So you have a positive deflection, initial positive deflection in V1 and V2. What happens if you lose that? You know you have septal infarction. If you have a Q wave here instead of an R wave, then you have likely have septal infarction. There's of course other rules for that. And if you were to look from the lateral leads, looking at V4, V5, V6, then you would see either positive or negative deflection depending on whether the septum was oriented superiorly or inferiorly. By that, I mean, in the usual condition, you're going to have initial negative deflection in V5 and V6. That's the usual condition when you have activity going away from V5 and V6. But there are some situations where the heart's a little rotated and the septum is being activated in an inferior to superior direction. And there you might have some changes with some of these leads. For example, in lead 2, 3, and specifically in lead 3, you can get a tiny Q wave in lead 3 because of inferior to superior activation of this septum. And what does that little septal vector do? It is essentially pointing, or the septal axis is essentially pointing downwards and to the right. It's pointing from posterior towards anterior, which is why we see these changes in lead V1 and V2, the positive deflection. And similarly, because it's coming away from V5 and V6, the negative deflections in those leads. As I said, lead 3 would typically be positive unless the septum is oriented, the heart is horizontal and you get a superior activation of the septum, and then you might have a Q wave in lead 3. Now, the next part of the heart to be activated quickly as the septum is activated is the anteroseptal right ventricle, and literally, if you could think about the tip of the heart, and there you're going to get a little more augmentation of this V1, V2, V3 changes, where it's going to be a little more positive because it's coming right at it. And V5, V6, looking from the lateral leads, is going to see activity going away from it, or negative tracing, negative deflection there. Apologize, didn't turn that off. And then you have a activation of the larger ventricular mass. And here's the effect of that. We know, you know, that the LV is large muscle mass relative to the right ventricle. And what does that then do for us? You have a vector then that is directed largely leftward. And because the left ventricle is a posterior structure and the RV is an anterior structure, you have a vector that's not only directed rightwards to left, it's directed leftwards, but also directed posteriorly and directed inferiorly, as you can see with this little vector diagram. In the frontal plane axis, this is our typical axis for the bulk of ventricular activation. Typically, obviously, lies anywhere between -30, beyond which would be left axis deviation, and all the way up to about 110 to 120 degrees. This entire quadrant here is going to be normal axis, if you could picture that. And as you look at the surface ECG, the net effect of it, you remember we talked about if you had a larger muscle mass and a smaller muscle mass, you get activation proceeding in the direction of the larger muscle mass unopposed. And so if you were looking from the right-sided leads, you'll see a rapid deflection downwards in V1 and V2, which are precordial leads, looking at the right side of the heart. And let me see if I can move this off. Okay. And if you were looking from the left side of the heart, obviously you're going to see positive deflection towards it. Now, the last part of the heart to be activated, and let me see if I can minimize that further. Okay, good. Is the late activation of the posterobasal LV, which will be this portion, and the pulmonary conus, and the uppermost part of the interventricular septum. These are the last parts of the heart to be activated. And is that meaningful to us in any way? It is a little bit. If you look at lead V1, you might have a vector that's pointing upwards and to the right and somewhat anteriorly. So it's a rightward vector largely. If you think about all of these structures, it's going to be a rightward vector because the the conus and the upper part of the interventricular septum are all anterior and rightward structures. And what that would cause is this RSR prime. And so this R prime can be completely normal activation and not necessarily bundle branch block or any other kind of abnormal activation. It's simply basal parts of the heart being activated last. So this is just normal cardiac conduction. The T wave vector, and we'll talk about repolarization perhaps in another session a little bit more, but the T wave vector is largely oriented high to low in the same direction as ventricular depolarization. So generally, you have positive concordance on most leads. By that, I mean, if you have a negative deflection in V1, you're going to have a negative T wave. And in V6, if you have a positive QRS, you're going to have a positive T wave. So typically concordant T wave proceeding from high to low. So you get an inferiorly directed vector of the T wave. And in the horizontal plane, pointing towards V5 and V6. So you could see it's going to be negative in lead V1, the typical T wave, and positive in V5, V6, or the left lateral leads. And so it's oriented leftward, inferiorly, and slightly anteriorly. Again, I said that we'd come back and think about this a little bit more, and I'm going to pull this up as part of some of our looks at some tracings and thinking about axis. And just a reminder that as wave fronts come towards V1, you're going to have positive in V1, but negative in V6. We've gone over this a couple of times now with these slides. Similar in V5, V6, the lateral leads. As a wavefront comes towards it, be positive in V5, V6, negative in lead V1. And I might be kind of hammering on this, but good to kind of keep in mind so that as you look at arrhythmias and look at site of origin of arrhythmias, then you can kind of be thinking about where something is originating and what makes sense and what doesn't. Now, what's the simplest way to think about cardiac frontal plane axis, which is our typical traditional way of reading EKGs? We look at rate, we look at rhythm, we look at axis, and then we start talking about the finer points of what's going on with the tracing. And if we are to look at axis, a frontal plane axis, the easiest way that you can do this is to pick out one of the frontal plane leads. That's lead 1, 2, 3, or the augmented leads, AVR, AVL, AVF. Pick out any of those leads, any one of those leads where you have a nearly isoelectric or isoelectric QRS complex. By that I mean, if you add up, I know these terms may be very familiar to you guys, but I'm just going to repeat them for what it's worth and say, if you add up the positive and the negative, that lead then is isoelectric for the QRS. So for example, in this example here, if lead 2 is isoelectric, then I know that the activation wavefront of the ventricle or the mean frontal plane axis is going to be perpendicular to lead 2. So lead 2 is in this example isoelectric. You add up the positive and negative, it's almost 0. And so it has to be then perpendicular. So then it's going to lie somewhere along this lead. And what is that lead? It's either going to be lead 1 or lead AVL. They should have marked this lead AVL. And so you look along AVL, which is perpendicular to lead 2, and decide in which direction your axis is. And if 1 and AVL would have looked identical to this, it's going to be positive, then your axis essentially points up towards the left upper quadrant right along -30. Now, what about, is this left axis deviation or not? Is this actually leftward? We know it's just isoelectric, so it's perpendicular to 2. If it was left axis, you're going to need to have it negative in lead 2. And why is that? We're going to look at an example here. It's because then if you have a left axis, you're to the left of -30. And so it has to be somewhere in this half circle. because remember, lead 2 is looking from this direction. This entire half circle is going to be positive for lead 2. And here's another example where I've just cut out just the leads that are relevant. And if I pick out which lead looks isoelectric. Okay, lead 1 looks isoelectric. If lead 1 looks isoelectric, I'm going to go perpendicular to it, which would be AVF, and decide, well, is my lead vector, is my ventricular vector or mean QRS vector or the axis, the frontal plane axis of this EKG, ECG, is it pointed inferiorly or superiorly? All I need to do is go perpendicular to lead 1, and that'll be lead AVF. And if it's positive in AVF, then I know my axis is pointing straight down. And if it was negative in AVF, it would be pointing the other direction. So this is the simplest way to think about axis. Obviously, you could do it differently, and you could actually resolve vectors in lead 1 and AVF. You could draw for yourself a vector along lead 1, which would be isoelectric. So it's essentially almost a 0. Let's say it's a short stubby vector that long, and lead AVF being dominant positive. And if you were to draw the perpendiculars, then you'll end up with a vector pointing in this direction. A little cumbersome, easier to quickly pick out which lead is most isoelectric and just go perpendicular to it. Let's take this example, and just to show you a little variation here, which lead is most isoelectric of these? I'd say that AVF looks pretty close to isoelectric. It may be, if you added that and that, looks slightly negative, but I'm going to call it isoelectric, close to isoelectric in AVF. So immediately I know, oh, okay, AVF is here. My axis is going to be perpendicular to AVF. So it can only be along lead 1. And so I come up and look at lead 1. I say lead 1 is positive. Fine. So axis of the heart is pointing leftwards close to 0 degrees right along lead 1. And then to fine tune it a little bit, you could ask, well, is it going on the negative side of lead 1 or is it on the positive side of lead 1? Well, to determine that, come back and look at what you picked here. You picked AVF. AVF you resolved and said was almost a net 0. But if you add that and that, you're going to say, well, AVF is a little bit negative. If AVF is negative, remember that this entire half circle is positive for AVF. Therefore, the axis needs to be a little bit to the left of lead 1 here, or a little to the negative side of lead 1. Why? Because AVF is not positive. The net resolution of the QRS complex in AVF is actually slightly negative. So axis is going to be somewhere here, let's say negative 5, 10 degrees, somewhere in that direction, but a very horizontal axis. Another example, let's see, which lead has an isoelectric complex? I'm going to pick lead 1 as being isoelectric. And if I were to pick lead 1, this is lead 1 here. And then I know my lead axis is going to be perpendicular to it right along AVF. Is AVF positive or negative? AVF is positive. Axis is pointing vertically downwards all the way to positive 90. And here, let's see why I picked this one. Well, first I wanted to think about the P wave vector or the P wave axis. Is this axis normal for the P wave? I would say not. It's negative in 2, 3, and AVF. And hence, we know this is an abnormal P wave, ectopic focus, not coming from the sinus node. Remember, the normal atrial activity is high to low, and this is low to high. So it is an abnormal atrial rhythm. It could be a low atrial rhythm and not necessarily a problematic or clinically relevant, but just for the sake of interest. How do we determine axis of the heart here? I'm going to pick lead 3. Lead 3 is this lead here. And I'm going to go, well, Lead 3 is almost isoelectric, so I know then axis is perpendicular to it. Then in that case, axis has to be right along AVR, which is this lead, which is this our frontal lead here. And if AVR is negative, remember I told you this is the only exception to the rule. You have a negative down here in this quadrant. So axis has to be pointing right along, right along positive 30 degrees would be axis of the heart in this example. We have just a few more minutes. I'm going to go through a couple more examples. And here's one where I hope the bottom ends of this thing project, but let's see which lead, how are we going to resolve this? Let's say that AVR is almost isoelectric. If AVR is almost isoelectric, then I know my axis is perpendicular to it, which is going to be right along this lead 3 vector here, lead 3 axis here. And if I come down and look at lead 3, and that's 1, 2, 3, and if I look down at 3 here, it's largely negative. And so then I know axis of the heart is pointing up leftward here. And that's to the left of negative 30. So I know that this is true left axis deviation. And confirmed by looking at lead 2, lead 2 perpendicular to it is lead AVL. And remember, anything to the left of that is left axis deviation. And so certainly this axis would be to the left of that. We know that's verified because lead 2 is negative. These are numbered kind of crazy, but this is lead 2, this is lead 1, and obviously this is lead 3. So lead 2 is negative, and so lead 2, the vector or the axis needs to lie somewhere in this half circle, because all of this would be positive in lead 2. So for it to be negative in lead 2, it has to be to the left of negative 30 degrees or left axis deviation. Now, before we look at a couple of tracings, the simplest way to think about rates is really to look at a sweep speed of 25 millimeters per second, which is how we record our standard ECG. What's kind of the quickest, easiest way to think about all our little blocks here, so you keep them in mind. Every millimeter here is 40 milliseconds. Every one of our small divisions. Every large box is 200 milliseconds, and 60 divided by the RR interval in seconds would give you the heart rate. And obviously, or let me just say simply, the simplest way to keep this in your head is divide the number of large blocks. 300 divided by the number of large blocks will give you the heart rate. So if you have 5 200 millisecond increments or 5 large blocks between 2 QRS complexes, your heart rate would be 60 beats a minute. And every millimeter is 0.1 millivolts worth of voltage. And obviously that's important when we're looking at ST elevation or ST depression. Again, I apologize if that's way too simplistic for you all, but I just want, sometimes I have hand a tracing to someone to read and they're kind of flummoxed by even what the heart rate is if it's not printed up at the top, and certainly never trust the machine reading. Thambu, can we go live and have someone comment on this tracing for us before we close? We just have a few minutes.
Sure. So would any of the postgraduate students like to take on this ECG?
And remember, I'm not your examiner, and I'm not, I'm just not here to beat you up. We're just going to look at the tracings and kind of work through them.
Okay, so I don't know, any of the first year postgraduates would like to take it on? I can see some of them are there.
Yeah, it has to be in order. You have to start with the first years first, because that gives the most breathing room to the senior students. We had the same system through our cardiology fellowship, and we always breathed a sigh of relief when it just ended with the first years. But hey, you know what, Thambu, I should do next time is I should get a list of names and I'll start calling on people, because I certainly won't be shy to do that. Come on, guys, let's have a volunteer.
Okay. How about Sakshi? Are you, I don't know if you can hear me. You want to have a go at this ECG?
Yes, sir. This it's a sinus rhythm ECG, sir. With the P axis, it's a positive P in lead 2. Uh, the the rate of the ECG will be
You don't have to be exact.
somewhere around 60 to 70. The axis, I would say the most isoelectrical lead that looks is AVF. AVF, it'll be along perpendicular to AVF will be lead 1. When I look at lead 1, it's a positive. So somewhere around 0 degree is the axis, which will be a normal axis.
Very good. Good. Keep going. You're doing really well.
There looks like ST elevation in the inferior leads, sir, with like lead 2, 3, and AVF with point 1 millivolt elevation in all the leads with this T inversion in them.
Okay. And do you want to just kind of summarize and say just what you think the diagnosis is?
Looks it's a sinus rhythm ECG with the inferior wall STMI.
Yes.
With the normal
Very
axis.
Good deal. Excellent. Really nice job. Thank you. And so I think what we want to always say is that there is a current of injury. So there's an injury current. So we would read this as exactly as you did, sinus rhythm with a rate at, as you said, in the 60s, 70s beat a minute, and with an inferior wall MI, acute with current of injury. And if you want to be more descriptive, you can say with reciprocal changes. We can talk about those later. Even though those aren't depression, you can see it's kind of almost a mirror image opposite of our ST elevation. In the high lateral leads, you have this reciprocal change. So really nice job. Thank you. And I just put that there just to highlight that. These currents of injury, how do you get them? It's because when muscle is damaged, you have a resting membrane potential that's a little more positive than normal muscle cells, and you have an action potential that's a little shorter and a little quicker than the normal myocardial potential. And the difference between this causes a flow of current towards the epicardium, then causes ST elevation in those leads overlying the segment of the heart or the zone where you have your acute injury. And there's some other theory there. There's also this concept of a diastolic current of injury with a shift in baseline. And that's in some ways a little artificial. It's to do with how our ECG machines interpret it. Because of this shift, it kind of overemphasizes the ST elevation. And that's really what this diastolic current of injury is, as opposed to a systolic current of injury. And those are the mechanisms here. And I just thought I'd put that up. And a quick taker for this one, and this is just going to be a quick show and tell here. I'll maybe take another volunteer to say, you don't need to read rate rhythm axis, just give me one abnormal feature here and we'll move along to the next tracing because I'd like to wrap up.
Sangha, if you're free, I don't know if you can hear me. Sangha, you're there?
Yes, sir.
Go for it.
Sir, the only abnormality I can find here is probably LVH.
Okay, yeah, voltage does look a little prominent, I'd agree. Probably doesn't meet criteria. We'll talk about that. We'll talk about it in a little more in a session. But I want you to kind of pay attention to this 2, 3, and AVF. And if you look here, you have not only do you have a good Q wave in lead 3 and AVF meeting more than 40 milliseconds, but you also have these T wave inversions in 3 and AVF. So even though you don't have a full pathologic Q wave in lead 2, you're going to have to call this as inferior wall MI age indeterminate. If we were reading in the heart station, that's how we would read it. Sinus rhythm with inferior wall MI age indeterminate. And we'll put up more tracings of these to go through. But yeah, so that's what I wanted to kind of draw your attention to on this tracing. Tambu, do we have time for one more, or are we out of time?
We have time for one more.
One more. Okay, then we cannot leave without a rhythm. So we'll do this one. Any volunteers?
Reba, I don't know if you can hear me. Is it okay? Do you want to take this one?
Yes, sir. The rate is irregular, sir.
Good.
There are no P waves. It's an
Okay.
atrial fibrillation.
Okay. So let's think about this for a second. In fact, it's fascinating. This machine read, which was also machine read as atrial fibrillation. But if you look a little more carefully, and V1 is an excellent lead to look for P waves. V1. It's sitting right there in front of both of the atria. It's sitting right there wherever the right atrium fires right at it. And look at that. That looks pretty distinct, doesn't it?
Yes,
that looks
sir.
pretty distinct, and so does that one. And now if you come to lead 2, which right at the bottom of the strip, you also see, but I do agree with the irregularity, irregularly irregular. Even though it's irregularly irregular, when you kind of pull back and look at it, there's some parts of it where you see some kind of organization, and I'm not going to make a big case for it, but there's a couple of beats together here, a couple of beats together here, and maybe some form of group beating. It's not entirely clear. Not the easiest tracing. So I wouldn't call that the easiest tracing. Let me see if I have a marker on this. Oh, there it is. Okay. Let me see if I can pull that off. I'm sorry, I might have hidden that there. I don't know if that hides on your screen as well. But I think I put this marker up to show you kind of the P to P interval. So if you look at that P wave is hiding right inside that QRS complex. And if you were to move this little marker along, that's a fairly decent approximation of P to P interval. So now when you look at it, you see P wave, P wave, P wave hidden in the QRS, P wave, P wave, P wave. Do you see that now? So the P to P is actually pretty fixed and regular, and somewhere close to 400 milliseconds, so about 150 beats per minute, the atrial rate. So the atrial rate is about 150 beats a minute. And as you very correctly said, the ventricular rate varying all over the place. So then you kind of have to try to kind of pull it together and try to make some sense of it. And then you might start, well, does this really make sense? Well, maybe it does. So possibly that P wave makes its way to that QRS complex. That one stretches even more all the way there. And this one possibly all the way there, or blocks. I think it's more likely it makes it all the way there, because this PR interval is way too short out of the blue for this P wave to be conducting to this QRS complex. So what we really have is a progressive lengthening of PR intervals until you have this beat, even though it's right in front of this QRS complex, this beat actually blocks. So you can picture this beat going nowhere. And this is the next conducted beat. So what we actually have seen here is what do we call this now? The person who is reading you, if you can think about PRs progressively prolonging, P to P intervals remaining fixed, and PR prolonging until you get a drop beat is called thank you. So a Wenckebach sequence or second degree type 1 block of an atrial tachycardia. So this is an ectopic atrial tachycardia, happily firing along at 150 beats a minute. And you can see it's a largely right atrial rhythm. Mostly P wave is all positive in Lee 1. There's not much negative left atrial action going on, pretty prominent on the early part of the P wave. Remember, we talked about those P waves being largely right atrial in the early part and left atrial in the latter part. This is another little quirk here where you have negativity in lead 2. It's possibly because of another condition called Bachman's bundle branch block, where you have abnormal activation from right to left. But I'm not going to kind of hammer you with those details at the moment. But just to appreciate that you always have to look out for, is there a P wave hiding someplace that I can kind of tease out and see if there's some consistency with it. But you're absolutely right to nail on that it is irregularly irregular. This Wenckebach sequence probably is going 4-3 and then 3-2, 4-3 and 3-2 alternating, which makes it not that easy to look at. But I just could not resist the temptation of putting one rhythm slide up. So I'm done with that. I believe we're right at 10:30. We may be a couple of minutes over. If you have any questions, how do I see the chat box, Tambu, or are you going to read me the questions if there's any? Or the team, the students, the PGs can feel free to please speak up. You're welcome to just speak if you'd like to, or if you already have questions in the box, I'm happy to answer them.
I think today there are no questions, Vijay, but I'll ask anyone to unmute themselves and ask questions. Guys, if there are any questions, you can feel free to ask Dr. Vijay now.
Wow. So, yeah, well, no questions. Hey, how about we go on? Is everyone expected to have their video off as well as their audio off?
We generally
have them?
No, we generally put the audio and video off so that some people with poor bandwidth, if they're far away, then otherwise the system, some people's system crashes. But we can have the video on if you prefer.
I just like to visit with them for just a moment. You could maybe stop recording and then we can turn the video on if anybody's